From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello and welcome to our listeners around the world. You're listening to our JAMA Clinical Review podcast. Thank you for joining us. I'm your host, Margaret Wheeler, Professor of Medicine Emeritus at the University of California, San Francisco, and an Associate Editor at JAMA. I'm joined by Drs. Bill Cliby, Professor of Obstetrics and Gynecology, the Division of Gynecological Oncology at Mayo Clinic in Rochester, Minnesota, and Dr. John Weroha of the Department of Oncology at Mayo Clinic in Rochester as well. They are authors of a JAMA review on the topic of ovarian cancer, and we'll be discussing that review today. Welcome, Drs. Cliby and Weroha, to this JAMA podcast.
Thank you, Margaret.
Thank you for inviting us.
Tell us how common ovarian cancer is, and what are the clinical risk factors that clinicians should know about when thinking about ovarian cancer?
Ovarian cancer is actually quite common and around the fifth leading cause of cancer death in women in the United States. Worldwide, I believe it's around the eighth most common. It has a very high death rate for cancers. It's not unfair to think of it similar to pancreatic cancer in that regard. So even though the number of cases in the U.S. is around 22,000 that present with new diagnosed ovarian cancer, the death rate is quite high. 1 out of 4 patients may have a genetic or familial risk factor, and that is a very high risk factor if they do have a genetic factor. But for 75% of patients, there won't be risk factors that are necessarily known. So I think most people present to their primary care, internist, family practice physician with new symptoms, and they're unsuspecting that they might have ovarian cancer.
So you said that this was a very deadly cancer, and that there are some patients that are very high risk. Are there ways of decreasing that risk or helping prevent ovarian cancer?
I think it's very clear-cut for those in family that have a high tendency for ovarian cancer. For the person taking care of any woman in the United States, taking some type of very brief family history to identify women who might have breast, ovary, uterine, or colon cancer in their families would go a long ways towards identifying people who might be in a family. A good example, in our state, we have a very active ovarian cancer alliance. And as of a few years ago, the most common way a woman found out she was in a family that has ovarian cancer is for her herself to get diagnosed with ovarian cancer. Then she was able to put together the family history. So it's not very widely talked about. So I think that's a really important one. For those high-risk women, removing the tubes and ovaries is very highly preventative for developing ovarian cancer. It reduces the risk to something like 5% of the background risk, which might be as high as 30 to 80% risk of getting it. That's very important.
John, I'll ask you this one. You said that it's a very deadly disease, that a lot of women who get ovarian cancer die from ovarian cancer, which would mean that screening would be a great idea to see if we could catch it early. What about that, John?
Indeed, screening would be a huge advantage to diagnose these cancers early and improve survival. Unfortunately, we don't have a good screening test. The best screening test that we have is really patients' symptoms, which obviously is not the screening test that you're referring to. Investigators have tried looking at things like CA-125 and doing pelvic ultrasounds, but it doesn't seem to help diagnose cancers early enough to make it into any kind of a screening guideline. These studies were done in patients who were already considered high risk, so BRCA mutation carriers. So unfortunately, there's no good screening test now, but there is a lot of research going into this. And I think in the future, we may hear more about screening tests for ovarian cancer, but at this point, it's still at the research phase.
How does ovarian cancer typically present, and what should clinicians be looking for when their patients come and talk to them? You said that was the only way to screen.
Yeah, so unfortunately, a lot of the symptoms that patients experience are very vague, very common. For instance, abdominal fullness, distension, early satiety. These are issues that many patients will experience even without cancer. So they're very nonspecific. A lot of times, patients will see a primary care provider with a chief complaint of constipation, and it gets managed as just constipation until it becomes so significant that a CT scan is obtained, and then you see the peritoneal disease there. So it really just comes down to symptoms and recognizing the symptoms of intraperitoneal disease.
And is there anything to help guide a clinician to think about these things, length of the symptoms, length of time that they have them, that they're not getting better? Are there other things like that that you would give us generalists as advice?
Yeah, I would simply recommend that if the symptoms are not being adequately managed with conservative treatments, such as over-the-counter laxatives and that sort of thing, then I would start investigating deeper. I guess I don't have a good sense for when you should get a CT scan, because obviously those are quite expensive and there is radiation exposure there. So clinical judgment here is just going to be really key. If symptoms are lasting longer than you would normally expect, then I would escalate the diagnostic testing.
Knowing your patients well, and they start to have 3 or 4 weeks of a persistent abdominal symptom, that's really out of character for that person. And like John says, again, even when you suspect it, it's difficult to diagnose, but ultrasound can be a simple way to start.
We see a patient, abdominal bloating, constipation, some abdominal symptoms, vague symptoms that are lasting for a while, maybe some weight loss. So we're starting to think maybe ovarian cancer, maybe something else, we're not quite sure. What would a diagnostic workup include? You mentioned pelvic ultrasound. Certainly if we feel something on exam, we might start there. What would you say we should be looking for?
Taking that family history at that point would be useful, just to make sure. I think broadly looking at causes of abdominal pain, and that might include, if you're going to get an ultrasound, I think most people would also probably send off a CA-125 and a CEA value. Make sure people are up to date on age-appropriate cancer screening to help rule in or rule out the possibility of something like colon malignancy as well. Pelvic exam is actually still useful. It's probably not very sensitive for picking up a very early ovarian cancer. But for a patient who has intra-abdominal spread, which is how most patients do present, a pelvic exam, if somebody's experienced at it, can be quite useful, and a good abdominal exam also to look for ascites or omental disease.
Typically, we would see then on pelvic ultrasound a mass in the ovary or the fallopian tube. Is this the time now to refer to the oncologist, or are there other things that a generalist should do before referring to you? When should the OBGYN and the oncologist be involved?
I think if you have abnormal ultrasound, that's a good time to involve an OBGYN, probably as the first step. Now, it depends on access, too. If you're in a particularly rural area or access is way out, then I think it's totally appropriate to go ahead and get a CT scan, which will help narrow it significantly. And if that CT findings are suspicious for cancer, then reaching out to an oncologist in your network for either referral or guidance on, is this something that should get a CT guided biopsy for diagnosis?
So now we've discussed diagnosis, and we've gotten some of the serum markers like the CA-125 and the CA-19-9, and presumably seen a mass or something on ultrasound and or CT scan. Let's turn to some of the initial treatments. You've said that most people present with late disease. Are there differences between earlier and late disease and how you would approach the patient at this point?
There are differences in terms of late and early stage. The biggest thing to think about is whether or not the patient is a surgical candidate. Because we tend to prefer, although there are differences around the country, we tend to prefer upfront surgery whenever possible, to resect as much cancer as possible, surgically debulk, before we then come in with a chemotherapy in the adjuvant setting to chemically kill any residual disease that's left behind. Usually, if surgery is feasible, we would prefer that. Does not look feasible, or it doesn't look like it's the right thing to do at this time, then we might do chemotherapy first. And then the type of chemotherapy we choose doesn't really differ between an early stage, let's say a stage 1 that needs chemotherapy, or a stage 3 or 4 that needs chemotherapy. That chemotherapy is the same, but what might change is what we add to the chemotherapy, or it might change what we do after chemotherapy ends, and that is stage dependent.
I think, John, do you think it's fair to say that early stage and advanced stage, it's less chronology and it's more that these are very different biological cancers?
Yeah.
And this is partly why screening is not very effective. The high grade advanced stage cancers, we as a specialty have done worldwide studies, including thousands and hundreds of thousands of women. And these patients can go from a normal CA125 and ultrasound and 6 months later have stage 3 advanced stage ovarian cancer. So if there is a precursor to advanced stage, it is a very short window. The ones we usually find that are early stage 1s and 2s, which are quite like any cancer, when it's an early stage, has not left the organ, is quite curable. There's a long window there. We think of those as more indolent type of tumors, spread later in the course of their disease, and we do have an opportunity to find those early. So they're just very different. We get lucky occasionally and find a high-grade tumor in an early stage, but that's the exception, I think.
Bill, surgery is really important to this. Can you tell us a little bit about what the surgery entails in early stage and later stage ovarian cancer?
Early stage is all about staging, surgical pathologic staging. Has the disease actually left the tube or the ovary? Is it really early stage, or is there occult metastases in the lymph nodes or the other organs in the abdomen? If so, that's much more in need of adjuvant therapy, the treatments John discussed, which are cytotoxic or chemotherapies. When we have a presumed early stage, that's all about making sure it really is early stage and tailoring the therapy. Advanced stage is the opposite. We know that they have advanced stage. We can see it on CT scan. There are a lot of intra-abdominal bulky lesions. There's often ascites, and it spreads and stays within the abdominal cavity most of the time. This can involve the omentum, the diaphragm, the surface of the liver, the spleen, areas of small and large intestine that need resection, the uterus, tubes, ovaries, obviously. So that surgery, and that's what John said, if a patient is both fit for surgery, not frail, not malnourished, and on the other side, a case where we feel with expert surgery we can remove nearly all of the disease, then we try to take that patient to the OR, because we do think that this debulking, this cytoreduction concept actually improves outcomes and survival.
So in early stage, you're not only treating the disease by taking it out, but you're also staging to make sure that it's really early stage.
Yes, and that staging information is both prognostically useful for both the patient and for the intensity of surveillance, and it's therapeutically useful because we're going to follow up on microscopic spread. We're going to treat that.
Okay. And in advanced stage, taking a lot of that cancer out, you're not using it to stage, but it's treatment, and that will improve survival.
Correct. We believe so. Yeah. There's some controversy in our specialty on that, but I think it's fair to say that if a patient can tolerate a surgery, and if it's done in an expert center where there's a high likelihood it's going to go well, no complications or few complications, and be successful, that is associated with the longest survival.
And John, do both early stage and advanced stage patients get chemotherapy?
Usually, yes. So there are nuances to that. We would obviously talk to the patient about that. But once there is any evidence that the cancer has escaped the ovary or fallopian tube, we'll usually recommend chemotherapy. So it could be that there is rupture of the ovary and there's spillage of cancer cells throughout the peritoneum, even if the surgeon finds no evidence of disease throughout the peritoneum or in any of the lymph nodes or the omentum. Just the simple act of spillage makes us worried enough that we would usually recommend chemotherapy. So it's almost everyone with evidence of disease that's left the ovary will be offered chemotherapy.
So what's the prognosis for early and late stage disease with treatment?
So prognosis is usually pretty good with early stage disease. So we can usually cure many patients with early stage disease. The advanced stage, though, is more difficult, as you can imagine. The survival outcomes are not nearly as good. Recurrences are fairly common. But there is hope because there are multiple clinical trials now trying to come up with new therapies in the frontline setting to see if we can improve the cure rates. And there are also multiple clinical trials trying to improve outcomes in the recurrent setting as well. So generally speaking, the outcomes are not as good as the stage increases, but I think there's enough research to provide hope for our patients. PARP inhibitors definitely revolutionize the way that we manage this disease, this cancer. It has improved not just short-term outcomes, but survival rates for certain patients with ovarian cancer. So PARP inhibitors really have changed our practice. And now with antibody drug conjugates being FDA approved, where the newest ADC that we use in the clinic has twice the response rate of any standard cytotoxic chemotherapy we have, is really impressive.
John, you used that term antibody drug conjugate and ADC, which is becoming more widespread. But can you just really simply just tell us what that is?
Yeah, so an ADC, it's one drug that's comprised of three key components. The antibody itself is an antibody that recognizes a target. In this particular case, I'm referring to the folate receptor antibody recognizing folate receptor on ovarian cancers. But what's really cool about this is that there's a chemotherapy payload that's stuck to the antibody through a linker. And the reason why this is so important is because this allows oncologists to deliver chemotherapeutic agents directly to the tumor cells that are expressing the folate receptor, for instance. And this should lead to improved toxicity profiles. And as we've already seen, it leads to improved clinical outcomes as well.
And any numbers that you could give us for clinicians talking to their patients with advanced stage disease about overall 5-year survival rates, anything like that?
Most recently, I think in the U.S., we've just passed the landmark where 50% of patients with advanced stage disease are still alive at 5 years. Now, a lot of this is predicated on the age and underlying performance status of the patient, of course, but every patient's an individual, and we talk about large numbers and we talk about percentages, but a lot of the prognosis depends on how early do we find it. So even if it's advanced disease, is a relatively small and easy manageable disease in the abdomen? How successful was surgery? Could we remove it all? And then the underlying genetics, not just the germline genetics of the patient, but the tumor itself, as it acquired mutations that make it more or less sensitive to chemotherapy. So again, it really requires individualization.
Final wrap-up question. Is there anything about ovarian cancer that we haven't gotten to?
For me, if you are taking care of a practice and more of a care provider in a longitudinal way, I think knowing your patient's family history and what they might be at risk for goes a long way towards identifying families. And then second is really paying attention to new and persistent symptoms and not being afraid to jump on those if you think the symptoms warrant.
And because I focus on the chemotherapy side of ovarian cancer management, I would just point out that sometimes our therapies do have some long-term consequences, such as peripheral neuropathy, some significant fatigue that can persist. And so we may need help from our general practitioners to help support them through those sorts of side effects.
Thank you so much, Bill and John, for being with us today and discussing your incredibly important work. We really are grateful to you for your review and this discussion that we've been able to have today on ovarian cancer.
Our pleasure, Margaret. Thank you.
Thank you.
Thank you for joining me today to discuss ovarian cancer. This episode was produced by Shelley Steffens at the JAMA Network. You can find the link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.